Okay, good afternoon, good morning, good evening, wherever you are. Welcome to CPD Global Medical Education Webinar Series. We have two excellent speakers today, and I'm very grateful to Dr. Mansoor Ali, the program coordinator, for coordinating these speakers. First speaker today, we have Dr. Saad Ahmed, who is a core medical trainee at Colchester Hospital. And he's going to give us an excellent talk on TMA related acute kidney injury. So over to you, Saad.
Thank you, Dr. Naqvi. Hello, everyone. Thank you very much for hosting me on this platform. I really appreciate it. So yeah, I'm a core medical trainee in Colchester. I was involved in the clinical care of a patient who had TMA-related AKI, which we'll go on to. And I was so enthused by the case that I thought I had to share it with all of you. So thank you very much. Just getting straight to it. So start with the case presentation. She's a 46-year-old lady. Her background is of high blood pressure at the age of 29, a bit sketchy about the history from there, how well it was controlled, some readings. She had a miscarriage as well at the age of 29, and also the history is a bit sketchy about, the age of gestation at which she had the miscarriage. On monotherapy for high blood pressure, good renal function in 2013 with a creatinine of 78 and an AKI many, many years ago. She was referred to the renal services with very non-specific type symptoms, fatigue, urinating at night, some nausea and vomiting. No overt risk factors that we could identify for acute kidney injury and no other systemic features. Bit of a busy slide, but the important things to mention from this slide is that she was very hypertensive. Blood pressure was 212 over 144. Nothing else, obviously, to examine for. And her creatinine was 418. And as we mentioned, her last renal function was quite a few years ago, 7 years ago, with a creatinine of 78. So she had renal impairment. We just weren't too certain if it was acute or chronic renal impairment. Hypokalemia at 3.1, and she was quite anemic with an HB of 85. And again, we were just thinking, is this in the context of a chronic kidney disease? She's iron replete, as you can see. Or is this in the context of an acute kidney injury and an inflammatory process going on there? She's also thrombocytopenic, as you can see. LDH is markedly raised, so it should be less than about 400 as a normal range. And she's got a raised reticulocyte count. Normal's about 30 to 100. So her bone marrow is working well. We did a blood film based on the thrombocytopenia. And the important thing I want to highlight here are these subtle red cell fragments that you can see. And below that, her clotting screen was normal. These are all within normal range. A mild rise in CRP, but nothing too significant. And this is her protein creatinine ratio, which shows 1 gram of protein, and her albumin creatinine ratio, which shows about 0.89 grams of protein. So a bit of proteinuria she's got as well. Okay, so I recognize the audience probably know a lot more about this than me, but if anyone did have any suggestions, anything else to work up to the patient? If not, we can move on. Okay, so to work up this renal impairment, we then did some additional bloods, did a myeloma screen that was negative, a vasculitis screen, which included ANCAR and all that, which was negative. The important positive things basically to mention here are these, as part of her antiphospholipid antibody screen, she had a raised cardiolipin antibody. Now, just to tell you guys about the normal ranges, 10 to 40 is considered to be weak positive, and greater than 40 is positive. So as you can see, her cardiolipin IgG was weak positive. We repeated the blood test after about 5 months, and her IgG was shown to be raised from 12 to 21, and her IgM was also shown to be raised, even more. Okay, because of a high blood pressure, was investigated for secondary causes of hypertension, which were negative. We did an echo on her that showed mild left ventricular hypertrophy. We looked in her eyes and it showed some bilateral hypertensive changes, hard exudates and cotton wool spots. And so she did have some evidence of end organ damage, as you can see. Chest X-ray was normal, which we did just to work her up. We did an ultrasound scan of her kidneys that basically showed reasonably sized kidneys, 115 and 102 millimeters, and loss of differentiation, so corticomedullary differentiation is what she lost here as well. She had an MRA, which is a magnetic resonance angio, to work up her high blood pressure, and that didn't show any renal artery stenosis. Okay, so I notice if anyone has any ideas or any mention about the issues that we've identified in the case so far, there is a chat here. So ultrasound, yeah, chest X-ray showing hyperinflation. Okay, yeah. Anything of any issues to mention from the bloods if we skim back here?
So what I'm going to do is I'm going to unmute all of you. So please shout if you have any
differentials at this stage.
comments on this case. Ultrasound was done.
Okay, so Imran says it's TMA related.
Very assertive, very assertive. So we didn't know that at this point. So what we found was that she had, as you mentioned, renal impairment. We weren't sure if it's acute or chronic. She had hypertension. I'm sure you all guys know that hypertension can be a cause of renal impairment or the result of renal impairment. She also had anemia. And as we mentioned, we weren't too sure, you know, is this just an ongoing process, CKD, or is it an acute inflammatory process? Anemia is normally associated with chronic kidney disease, but we were a bit concerned here. And these fragments, the hematologist said they're subtle, but, you know, do we just ignore them or do we go on? So just describing it, what we felt was she had what's called a microangiopathic hemolytic anemia, which basically is demonstrated by the hemolysis, these raised reticulocytes, the anemia with the HbF85, and these subtle red cell fragments. She also had a thrombocytopenia, and it was dropping. Her platelet count went from 96 to 83, and she had renal impairment and high blood pressure. The other things to mention are she had raised antiphospholipid antibodies. And I know, you know, often when we send off lots of blood tests, some stuff come back positive and we're not really sure what to do about it. So over here, to be honest, we weren't sure about the significance of the antiphospholipid antibodies. Given they were raising, given there was this history of miscarriage, we felt we couldn't really ignore them. So absolutely. So these were the kind of issues that we felt. Kidney impairment, acute or chronic query, MAHA, which microangiopathic hemolytic anemia, and TMA. I'm sure all of you guys know more than me about TMA, but it stands for thrombotic microangiopathy. And it basically is a pathological lesion that's seen under the microscope. And it refers to basically small vessel thrombosis and occlusion of blood vessels, commonly the small kidney blood vessels. The presentation of a TMA essentially depends on the site and the size of the blood vessel that's affected. So for example, if it's in the kidneys, their TMA, then it will of course an AKI. That's a bit of a simplification. And then the high blood pressure, what's going on there? She's had high blood pressure for quite a few years and the antiphospholipid antibodies. So yes, MAHA we just discussed about these schistocytes, these red cell fragments, and this whole hemolytic process, a non-immune process. And TMA, absolutely, we spoke about a pathological lesion. And we're going to discuss TMA. It's quite a complicated thing, but it's important. The purpose of the talk is just to talk about recognizing a TMA suggested by thrombocytopenia and a microangiopathic hemolytic anemia. And these cases do come into general practice and into acute medicine. In the last 4 years, I've seen about 2 or 3 cases. So that's really the main take home from this talk, just to think about it when you see an anemia and thrombocytopenia. Okay. A bit more, we normally think of TMA as this process, which it mainly is. But I think academically, the pathologists also talk about more chronic TMAs, which have been going on, niggling there for quite a few years, and that causes this subtle kind of renal impairment. Okay, and just talking a bit more about TMA, TMA can essentially be divided into hemolytic uremic syndrome which is essentially quite a severe AKI because of post-acolytic diarrheal type illness. And it's not as simple as the diarrhea causing hypovolemia and a pre-renal AKI. It's not as simple as that. It's really this thrombotic occlusion in the renal blood vessels. So it's quite a nuanced process. And then there's TTP, which is thrombotic thrombocytopenic purpura, which is a life-threatening condition that has a 90% mortality if it's not treated and diagnosed accordingly. And it's really suggested by a severe thrombocytopenia. Yes, we'll go into this slide. Normally the platelet count is in single digits and they have focal neurology, commonly a low GCS. So often these patients actually need to be intubated and transferred to tertiary care centers. So that was another highlight of this talk, how early recognition of the TMA and discussing with tertiary care centers, because often the treatments that they have available are very specialist driven, and in DGHs and all, we don't know a huge amount about them, require a lot of close monitoring. Then there's this AHUS, which stands for Atypical Hemolytic Uremic Syndrome. This is really a diagnosis of exclusion. Once you've said, it's not HUS, it's not TTP, it could be atypical HUS. And just to bring 60% are due to secondary causes. And in our case, I'd like to bring your attention to these causes we've mentioned: malignant hypertension and autoimmune disease. And the autoimmune disease in our case, which we were querying, was antiphospholipid syndrome. It can also be caused by SLE as well. So yes, so this is where our case fits in. It fits into this atypical hemolytic uremic syndrome, query hypertension, query autoimmune, and then 40% are due complement overactivation. Now, just a bit about TTP. We really, sometimes it's not clear from the history or the blood test what type of TMA the patient has. And from speaking to renal physicians, that's quite normal. It's just important to recognize that there could be a TMA and to discuss them with tertiary care centers early. And for TTP, the hallmark is this low ADAMS13. I'm sure all of you know much more than me about ADAMS13, but it's really this enzyme that cleaves these von Willebrand multimers. And if it's not there, then they really clump together and cause this microvascular thrombosis. So that's the hallmark of TTP, a deficiency in ADAMS13. Okay, and this slide just gives you a bit more detail about that. I know time is quite limited, so just minimal or no renal impairment in TTP, subacute AKI and AKI in HUS. STEC stands for Shigella toxin. So often in these patients, we do send off stool cultures, and the labs can test for Shigella toxin, and they can also test for E. coli, substrain 0157, I think. But that's the important blood test to do if you're thinking a TMA. Send the stool off. Okay. And then this slide is not to read, it's just to highlight how TMA can be caused by so many different conditions. And the key point of the talk is to recognize the pattern of involvement in a TMA: anemia, hemolysis on the blood film, and a thrombocytopenia. That is the main thing to look for. And this shows, again, just a bit about the different types and features of a TMA. And I'll just bring you in, hone you into our patient, who we feel could have an APS-associated nephropathy. APS stands for antiphospholipid syndrome. And this is where we felt our patient fit in. There is also this condition called catastrophic antiphospholipid syndrome. I don't know if you guys have many experience of that. It'd be good to hear from the audience after, which is really this widespread thrombosis. This quite severe digital necrosis with ulceration. And we had a patient who had recurrent thromboses, and the vascular surgeons managed her initially. They did aortic stents, iliac stents, and they didn't work because she kept on clotting them. So you can give all the stenting you want, you can give IV heparin and thrombolysis, but you have to really treat the cause, which is immunosuppression. Again, very complicated, very subspecialized stuff. Okay, and this just highlights how all the best doctors in the hospital are involved with treating TMAs. And blasphemy, I didn't just all doctors can see it presents to a wide variety of specialties. Okay, again, a very busy slide, and I just want to bring your attention to this ADAMS13 over here. And if it's less than 10%, you've got the diagnosis of TTP. PEX stands for plasma exchange. This is really when you replace the blood in the body. And the purpose behind this is to remove these, is to replete Adam's 13 and to remove like these autoantibodies that are produced. So that's the reason behind giving plasma exchange. And this is given, you know, in very specialist centers. So in Colchester, our nearest center is University College London or Cambridge. Okay. And just a bit about Adam's 13. Again, just in this slide, I want to bring your attention to this 3-day turnaround time, which is the 4th bullet point. And this, what this really says is that you don't wait for an Adam's 13 result before saying it's TTP. You just look at the clinical history, and if you think there's this thrombocytopenia and this hemolysis, it could be a TMA, it could be TTP. You're not going to say, I'm going to wait for an Adam's 13. And just to put the bullet point above it, this differentiates HUS from TTP. This is the key blood test. A bit about complement testing. This comes down to when you have a TMA, what are the blood tests that you look for? You check an autoimmune screen, like we did, an antiphospholipid screen and a vasculitis screen. And if you recall back, you have got atypical hemolytic uremic syndrome that can be also due to a complement nephropathy. And that's why C3 and C4 levels are so important. And these go to a specialized center in Newcastle, I believe, which is where they like to keep a national database of these patients. Okay. And absolutely, a renal biopsy, very important. It's done in renal medicine. If you don't know why the patient has AKI and you've stopped their nephrotoxics, you've repleted them with fluids. Okay, so that was the purpose of doing a renal biopsy. And this was our patient's kidney biopsy. Now, if there are any pathologists in the audience, if you guys could help us here. Otherwise, I have actually got the formal report next to me. Or Dr. Ali, if you want to take us through it, but there are these double contour signs which basically suggest chronic ischemia, fibrin thrombi, and shrunken glomeruli. So, you know, that's really what this biopsy is showing. And the pathologist, we contacted her after this, and she said this is quite characteristic of antiphospholipid syndrome. And the pathologist's job is really just to say, you know, what are the differentials from what she's seeing in the microscope? And it's our overall job to bring the relevance of the antibodies in. Okay.
Just to add something, Saad, so all TMAs actually share similar renal pathology. And I think, as you rightly pointed out, it's the fibrin thrombi within the glomeruli causing renal ischemia is actually pathognomic of TMAs in renal biopsies. And obviously, the clinical scenario, the presentation, underlying sort of cause, and autoimmune screen would really help us to differentiate one TMA from the other, which he'll elaborate on in the next few slides. Thank you.
Absolutely. Thank you, Dr. Ali, very much. So again, absolutely. So again, in our patient, could she have an AKI secondary to a TMA, query hypertension area base, or could this simply be what's more common, which is a high blood pressure that's causing CKD and a chronic TMA picture? So quite a nuanced type case over here. So what did we do? We tried to sort out her blood pressure by giving her antihypertensives. That was the first thing we felt we should do. And most importantly, we also anticoagulated her. We gave her some warfarin and switched this to apixaban. Now, this was a bit of experimental medicine. The reason we did that was basically what we're saying was that the antiphospholipid antibodies are quite relevant, and she possibly has got antiphospholipid syndrome. And that's why let's anticoagulate her and see what happens. And this is what happened. So her blood pressure came down nicely to 129/75. Her LDH significantly improved, and her platelet count went from being in double digits to, you know, peaked at 300, then to low 200s. But the key purpose of this talk is to look at her renal function and how this changed with anticoagulation. Her protein creatinine ratio almost came down to normal from what it was, which was about 1.8 grams. And her GFR also significantly increased. And what we were basically thinking was that if this was a TMA due to high blood pressure, we wouldn't really see such a dramatic improvement in renal function. So did our anticoagulation strategy work? That was the food for thought. Absolutely. We have discussed, I'm probably short of time actually now, but discussed it that, TMA is hemolytic uremic syndrome or TGP, or the diagnosis of exclusion atypical HUS. And essentially, it doesn't really matter what it is. The important thing is just to recognize it could be a TMA and referring essentially to tertiary care centers. Antiphospholipid syndrome, unique in the clotting diseases of causing arterial thrombosis as well. And there is also the Sapporo criteria, which talks about classifying antiphospholipid syndrome, can be primary or secondary. And essentially, the antiphospholipid antibodies have to be persistently raised over a period of 12 weeks, which they were in our patient. Again, there's a lot of research out there and opinions about the relevance of antiphospholipid antibodies. Some are more associated with thrombosis than others. Okay. And yeah, just a bit about the three main types of antiphospholipid antibodies: anticardiolipin, which our patient had raised, anti-beta-2-glycoprotein, and LA, lupus anticoagulant, which is historically more associated with thrombosis. Okay, and this just talks about the relevance of them, that you can't just see a positive result and say it's APS. You have to demonstrate that it's raised. Okay. And the treatment of antiphospholipid syndrome is anticoagulating them. That's essentially the purpose of this slide, with associated target INRs. And it's normally long-term warfarin or a long-term NOAC, which is a very significant treatment. Yeah. Okay. And then just one paper which we found, which was on the role of anticoagulation in TMAs. Do you give it or not give it? A TMA is essentially thrombosis. So many would say this patient has got evidence of thrombosis and has got a raised antiphospholipid profile. Okay. And just to bring your attention to these two graphs, all patients and patients who have antiphospholipid antibodies. And if you just look at the complete response, CR is complete response, PR is partial, don't know if that's written there, and NR is no response. So in patients who have got antiphospholipid, thanks, antiphospholipid antibodies, but not necessarily antiphospholipid syndrome, there clearly is still a role for anticoagulating them. Look at the significant difference in response between the two groups.
मेरी class fellows एक अपना वो करते रहते हैं
Essentially, that was our case. We said it's high blood pressure related TMA because of the severe high blood pressure, the reversibility of the MAHA, APS based on these niggly antiphospholipid antibodies. Why are they there? The biopsy, which Dr. Ali mentioned, suggests a TMA, well, is a TMA, but more characteristic, possibly APS, and this miscarriage history. Now, there's a bit more detail we need to dig. If the miscarriages are more than 10 weeks, you need to have one and you fit the criteria. If they're less than 10 weeks, you need to have 3 or more to fit the criteria. And background CKD was also based upon, yes, the long-standing high blood pressure, end organ damage, and the kidney ultrasound scan changes. Okay, I think that's it. Yeah, take-home messages. TMA is an emergency. If you see a MAHA and thrombocytopenia, it could be a TMA, HUS, colitis and diarrhea, TTP, focal neurology. That's really the main take-home. And I think that's, yeah, TTP will kill quickly. It's the one that's life-threatening. Plex, immunosuppression, rituximab, and that kind of stuff. And yeah, this last bullet point, the low titers could be of relevance.
Thank you very much, Saad. It was an excellent talk. We had a few questions. We will take questions in the later, after the second talk.
Yeah.
I would now like to invite Shaheen Kausar, who has joined us from Bradford Teaching Hospitals. And she's going to, this is a kind of a non-clinical talk, but a very relevant, very important one, especially during COVID pandemic. And Shaheen is a Muslim chaplain at Bradford Teaching Hospitals, and she's going to talk to us about the role of chaplaincy during COVID-19 pandemic. So, Shaheen, over to you. Thank you.
Sorry, Saad, could you just unshare your screen, please? Yeah, could you just stop sharing your screen? Thank you.
Thank you.
Yeah, Shaheen, we can hear you. Go on.
Assalamu alaikum. Hi, good afternoon. My name is Shaheen and I am one of the chaplains for Bradford Teaching Hospitals. Thank you very much to Dr. Mansoor Ali, who has given me this platform to share some of our work. And Dr. Mansoor is loved by all at the hospital, whoever comes into contact with him, whether it be patients, staff, or anyone. So, alhamdulillah, thank you for that.
Thank you. Don't let me leave the session. Don't just carry on with your work. Thank you.
So I know that there's 20 minutes, and I'm going to use that very wisely, especially because I want maybe some interaction from yourselves and some questions. And I believe that there's all clinicians on the other side. So it'll be really interesting to for you to think about whether you would call a chaplain or how you'd involve them in your line of work. So ordinarily, the hospital employs 7 chaplains of various different faith backgrounds who are paid by the trust, and most of the chaplains are part-time. As soon as COVID sadly came about last year in March, most of the team either was off ill or was isolating, which left myself as the only female or the only Muslim chaplain in the trust with a Christian colleague. What we found very quickly was all the calls which were coming in were for the Muslim chaplain, which put immense pressure, because we've never seen chaplaincy being in this level of demand ever in my 12 years of chaplaincy. And what were the calls about? So there's local lockdowns, restrictions, hospitals had gone into complete shutdown so that families could not now come in. So the role that I had to play was one of, often I would become a family member now to the patient who was in the hospital. That was the only thing that I could think of doing slightly differently than I was doing before, is either becoming somebody's daughter, somebody's sister, somebody's mother, because the family could not be in. And you can imagine the level of responsibility that holds. And I still do pray to Allah today that please accept everything that I did. Yes, we are there for the patients, and we draw alongside the patients who are often quite sick. There is a lot of distress when patients come into hospital. But here, the distress is slightly different because the families cannot be beside the loved ones. Now, often people are coming into the hospital with COVID symptoms. So people have got CPAP machines on. Everyone's dressed in gowns. So these are some of the things that I'm telling you that we are dealing with in Bradford. We have lots of people who are from the BAME community who are affected, in particularly the Muslim community. Some of the problems is that these patients who are coming in or largely could not speak English. Now, if they can't speak English, who are we relying on? Interpreters. Can interpreters come face to face? Because some of them were also shielding. So we're trying to do face and Zoom calls. So there's hardly any contact with somebody who is similar to themselves. So I then had to quickly adjust myself, dressing in scrubs and having in particular a red and white hat so that I could stand out from everyone else, because we've all got the same uniforms on. We are all in scrubs, we're all in gowns, we've all got visors on. But along comes the chaplain who has got a red and white hat on. We know she's arriving. That was my first sort of thing in terms of putting the patient at ease and then know that this is the same person they're seeing time and time again. The trauma will never leave me, I don't think. I think that every time I went to a patient, and I think we all know that having that CPAP machine on for hours and hours and hours, what happens is that the patient's mouth will get very, very dry. And going up to a patient and the first thing they ask you is, I just want a drop of water. Can I just have a drop of water? We're asking the staff, they won't give us a drop of water. And it's trying to relay that information back to the staff. And I know why they're not allowed to have the water, because they take the mask off, the oxygen levels will drop. And it was hearing that constantly. My job was to try to reassure the patient, pray with the patient, whatever it was, doing video calls with the family so that they can see the loved one. These are some of the things that we did in Bradford, and we did very, very well in terms of chaplaincy. What they could have done better is employ people who had the skills of chaplain to be a chaplain. So bringing in an imam, does that make a good chaplain? Or bringing in somebody who has religious knowledge, does that make a good chaplain? These are some of the things that to think about. Actually, they don't make good chaplains because A, you do not understand the setting that we are working in within the National Health Service, and And the demands and the things that we see, do we understand illness? In 12 years, the amount of things that I've learned from clinicians, it's taken me a long time. Do people have compassion, care? Do they understand privacy, dignity? You know, there's so many things which are wider, understanding some level of illness about COVID as well, how it will affect people, long COVID symptoms. We'd seen very, very young deaths with some people. I think that I was working 13, 14 hours at a time just to meet the needs of the patients. And I would like to just go to one example in particular, because it will always stay with me, is one of our very first deaths, early April. Patient was in ICU, and the doctors had now, at this point, the consultants had said that there's nothing more they can do. She's actively dying, but the family may not come. At that time, the family weren't able to come in. So I got invited to please come along. The chaplain will come and do what she needs to. I didn't know, and I was never prepared for that. There is a screen, a monitor, and there is about 30 people, loved ones of this lady. And this lady is dying, and I've got the consultant whispering in the ear, I will tell you that when she will go, and you communicate to the family. And I've got a couple of staff at the same. So at this point, I am relaying whatever the family. So there's a son who said, can you please kiss my mom? Bearing in mind, it's COVID, and everyone is very, very scared. Although I've got my PPE on, I did everything that the family asked me to do. So I kissed the mum. Another son, can you please, my mom's right hand, can you get her to wave at me like she's waving? I did that. Another request from the husband, and the requests kept coming, and there was about 30 people. And whilst I'm doing all the things that they're asking, the consultant whispers to say that she has died. I have to now relay this information back to the family to say she has died. So I'm calming the family, because the requests are still coming to say, can we please just take 2 moments and you need to listen. So I said, I'm very, very sorry, but she's no longer here. And her soul has left. And that's when it just broke out, the screaming, the crying. And at the same time, I am very acutely aware of the patient. This is ICU, the old ICU, which is very much Nightingale ward. There's a patient who's across who could hear what was going on. That was probably one of the most difficult things I had to do. And I think nobody was prepared for that. What came next is something very interesting. I knew by talking to the Council for Mosques that they were very concerned whether people will get shrouded, whether the people are going to get, the deceased will get washed and shrouded. So I had thought about this earlier on and thinking, what would be the reasons for why? And some of the reasons were, if there is any fluid in the body bag, that's it, the body bag will be shut, and they would have to, the shroud would go over the body bag. That didn't quite sit right for me, because I think a person's, the rights of a person is that they should be shrouded, they should have the ghusl, the janazah, all these things. So what I started to do is train the staff in the hospital to say, right, if we get a patient who is Muslim, can we make sure that there is no fluid in the body bag? And I help them to wipe down each time a patient was dying, to give them a bit of a bed bath, so that we weren't letting anyone go with any drips of any kind of fluid, whether it be blood or anything. So that worked really well. As far as I know, there wasn't a single person in Bradford who did not get washed and shrouded. So that was very early on. At the same time, I worked with our mortuary technician, and he was very helpful in saying that if there's anything that I can do in terms of spraying the bodies down with specialist substances, I will do that, so that your Muslim community is not going to be affected in any way. So there was a lot of thinking, but very ad hoc thinking going on, in making sure that we weren't, because family members couldn't come, we didn't want to upset anyone, that things weren't done right. Often families would attend in the car park. Of course, naturally, they're upset that they have somebody dying inside. We would go outside, take some bottles of water, console the family outside in the car parks. I think it's pretty much, when people have said it was like a war zone, it was like a war zone. And it's something that will last forever, because we were dealing with 5, 6 patients dying a day. So my heart is still heavy, my mind is still heavy, and all I do is pray that God accept everything that I did or my colleagues did for the community in Bradford. And at the same time, we were also seeing patients who were not of the same faith as myself. So it wasn't just the Muslim community, it's about everyone. You know, the little old lady, Mrs. Jones, who she's not allowed to have visitors, she's in her 90s. she's struggling to feed herself. We are short-staffed. We will feed you. We will look after you. Does somebody's hair need combing? These are not things in my job description. We will comb your hair because I know how it can, well, I don't know, but I can start to imagine somebody with a CPAP machine on with, you know, straps at the back, you know, and the hair, and you can just visually see the distress. So we did, as chaplains, whatever we could do to put the patients at ease. And I think that's primarily the job and role of a chaplain, is trying to put the patients, the families at ease, keeping into close contact with families, and then going back and staff being traumatized and going to listen to the staff, support staff, sit in the teas and coffee rooms. So in a nutshell, those are the kind of things that I myself did as a chaplain. So I'm going to now open it up for questions, because I think it's, you know, there must be lots of things that I forgot, but, you know, so yeah.
No, thank you very much. Thank you, Shaheen. I think that was truly emotional, truly beautiful. I know how hard you've worked and how amazing you've done actually over the last 12 months or so. Myself actually being a witness to all of this. And I'll just invite my co-chair, Naseem, to come on board, and we will just open the floor now to the audience for questions. Before that, Naseem, you've got anything to say, to add?
No, I think it was a fascinating talk. Thank you, Shaheen, for all the hard work that you are doing. You are amazing. And we've got some excellent comments. People saying, thank you, Shaheen, thank you so much. You are a legend, somebody said. There is amazing work, Shaheen, from Sadaf. We have a comment from Dr. Saad Ahmed. Shaheen, you are a real hero. So we have got some excellent comments. A question about using technology to good use, but dealing with ill patients, such as using Zoom or video calls with families. Are we using that, or?
Yes, so what I used to do is I used my own personal phone initially, because we didn't have anything like that set up, and I just had to think out the box. And for me, it was fine. If I did a 13-hour shift and I had to go back the 14th hour, I would do that, because last Ramadan, we had a young lady who was dying, and her husband said, all I want is, Shaheen, please, for her to have the kalima, just for her to have, and those words, I remember thinking, my gosh, what if I'm not on shift? So I made sure that I told the staff that please, if it comes to that, call me. I don't care what time, day, if I'm on shift, off shift. And I remember doing a 13-hour shift, and I got a phone call from ICU to say she's now dying. And I raced to ICU, got in time for the kalima, to do all the things that the husband wanted, but he was allowed to come afterwards, and that was very emotional. So we started to use, they've got iPads now at the hospital, so we have got a system now, and they did get it quite quick, but I suppose not quick enough.
Yeah.
I remember Shaheen actually doing non-stop days a week during the first lockdown and the pandemic, and I think you have done an amazing job, Shaheen. You were kind of actually one of the only ones, I should say, who stood out, who kind of actually run from one ward to another just to be there with families. You've not really worried about yourself, your health, your sort of family, because your hospital, your patients were your family, and you gelled in so well. You are a well-respected colleague, Shaheen, truly well-respected.
Yes, indeed. We have questions. This question is for Saad about use of IBGTN. I think, Mansoor, you answered that question already.
Yes, I did. Yeah, I did. Yeah. Shaheen, just wanted to kind of actually, I think someone's texted me asking, you know, how was it basically with other sort of chaplains? You know, I know how it works at Bradford, but the question is, was there an on-call rota for chaplaincy? Was there, you know, how did you work with your colleagues? Who could have decided where to go and which patient to see? Or, and as you said, you were not only for the Muslim patients there, you were there for everyone. Elaborate on that.
You're absolutely right. So we are there for all the patients, but we do have faith chaplains, Christian chaplains, Sikh, Hindu chaplains. But like I said, the need was predominantly for them. We work 24 hours, 24 hours, and that only came about is when we got some bank chaplains in. We've just recruited another 10, but things came a little bit late. Like the first cohort of bank chaplains, they came at the back of maybe Council for Mosques, but they weren't trained. So I had to provide them with the training as much as do the job on hand, and provide training to these new recruits. And like I said, you know, just because if you are an Islamic scholar doesn't make you a great chaplain, or if you are an alima doesn't make you a great, it's not all about Islam, it's understanding the healthcare and the wider picture. So that's how we read Rota.
Yeah, we've got a question, Naseem, from a colleague, Sadaf Jaffarboy. She's asking, was there any issues actually when attending male patients as a female chaplain?
Yeah, I got asked that at another presentation. Alhamdulillah, there was never an issue, because I know that when they say that there's a crisis point, if you're in a warlike situation, it's a little bit like if you only have a female going to the doctor and the only qualified person is the male, then it's absolutely fine for the male to be seen. I was tying men's hands and, you know, straightening out the bodies who were men. And my intention was very clean towards these people, that these are my brothers, my fathers. That's how I perceive everyone. And it's, I suppose, for God to judge that whether it's the right thing to do or not. I was always very aware not to step the line. But we did get a mail in about 4 weeks later. But I would say that for 4 weeks, I did do quite a bit of touching the males. And no family they're absolutely fine with that.
Shaheen, another question, a text actually has come through, which saying that basically, how has this personally sort of and emotionally drained you? How did you sort of, obviously being there, seeing death after death, you know, we had lots of deaths at Bradford Teaching Hospitals. How did it emotionally affect you?
Yeah, it's a great question. I have, till this day, I'm still struggling to sleep. So I'm still struggling to sleep, where I sleep for 4 hours and I wake up for about half an hour and then I sleep, and that's been ongoing now for a while. And going back a few months, what used to happen is I would have a flash of, bearing in mind that there's been over 200 patients who have died, have been part of their journey and their family's journey. And some of these people just would flashing in front of my eyes. And I've gone past that hurdle. So I'm slowly healing. And with my faith, I suppose it keeps me strong that, you know, this is a time and it will pass. There is now a really good team. There's many, many people in the hospital who are great, who are always there to listen to me. And I think the biggest thing is that for me to talk. So this is a way of healing as well. For me to sit and share my story is a way of healing. So yes, I am getting there. Alhamdulillah.
Alhamdulillah. Any other questions from anyone else for Shaheen or Saad? I mean, I'm sure you can be unmuted and you can personally directly ask questions to Saad and Shaheen.
Yeah, I'm going to unmute all of you. So please go ahead if you have any questions.
There's a question from one of our colleagues, Dr. Maaz Abid, truly enlightened. How can we raise more awareness for such basically roles at national level? Maaz, go on.
Yeah, for me, I think it needs to be done in Parliament. And I think that Bradford should be the beacon, because we've got a lot to celebrate in terms of everything that we've done in Bradford. I'm not saying this is nothing to do with me. I think as Bradford per se, the hospital and the wealth of experience and the things that we see in terms of illnesses, diagnostics, the cultural and religious competencies, there's so much that happens within our hospitals. And I do think, you know, if anyone is in a position to do that, take case studies to the House of Parliament and, you know, share that what's happened in Bradford. And if it's going to raise awareness nationally, then alhamdulillah, you know. So, you know, if anyone is able to do that, I'm more than happy to come along or whatever.
I think you should take this forward, Shaheen. I think you should take this forward. We'll back you. Just wanted to ask you, Shaheen, have you heard of any of such roles actually elsewhere in the trust? Because I'll be very honest, before the pandemic, my literal limited interactions with the chaplaincy was either during the Friday prayers or sometimes on a Sunday when a Christian chaplain would come and talk to patients, basically. That was the only limited interaction. But literally in Bradford, I think we're the pioneer, and you said a beacon of hope for lots of patients. And what you have done, I just want to know whether, have you come across anything else that's happened in the region or outside the region?
So there are many chaplains up and down the country, but I think Bradford probably has the highest number of chaplains. And I think the way they are selected is depending on how many inpatients you have of that particular faith background. So I know that there's a full-time female in Sheffield. There's pretty much a full-time male in Leeds. And probably, and I think there's lots more. There's a very good male, Yunus Dudwala, Mullah Yunus down in, and he manages 5 hospitals down in London. So there are many, many hospitals, but there's not enough hours for chaplains. So I've been now given a full-time job after working there for 12 years. And it should have happened a long time ago, because I actually did so much things out of my own time, and I still continue to do that because I have passion for the people that I work with. For me, it's an honor to be with the patients. It's not even a duty. It's not even something that I would think, you know, I would do it freely, absolutely freely, because I genuinely, I love seeing people who are, or I love helping people, I suppose. I suppose that's the best.
For that. You are a selfless person, and you've actually dedicated your sort of last 12 months, even more than that, to everyone basically who was admitted to Bradford, including colleagues. You actually held colleagues' hands, nurses and staff who were down, and I think I've truly seen that. Thank you very much. Any other sort of questions for colleagues? Sorry, Saad, you didn't get any questions, because I think everyone was interested in Shaheen's story, I think.
I really don't blame them. No, I really don't blame them.
Okay.
There's a question from Mohammed Gangu. She's saying Shaheen should share her COVID experiences to encourage people to get vaccinated also. Yeah, good point. Yes.
I will be doing that with Dr. Mansoor after we get together. After this, we will be getting together and we'll be doing that.
Yes, we've got a little plan actually. Inshallah, we will look forward to that. Yes.
CPD certificate link has been shared in the chat, so you can click on that link and save this CPD certificate.
Shaheen, we've got a range of doctors here: consultants, trainees, GPs, you know, surgeons. Anything you would like to kind of actually ask them, because obviously you've worked with me, but anything to my colleagues about how they have felt, and what kind of actually chaplain services have they sort of experienced during the last 12 months? You can ask them. Yeah.
Yeah. Before I ask, I realised that Sadaf had her hand up. Did you want to say something, Sadaf, before I say something?
Thank you, Shaheen. I think Mansoor and Naseema ignored me. Thank you.
Oh,
Guys.
sorry, I didn't realize that, did I? No, I would never ignore you. Never, ever. You know that. Would never.
Shaheen, I just wanted to ask, I'm sure many of my colleagues would have felt the same, like, you know, as chaplains, all throughout my training, all throughout my career, all I've seen is Christian chaplains coming along the way to the wards. I can't remember a single time when I have seen a Muslim chaplain coming to the wards. And I work in an area which is quite Muslim dominant. Is it because the trust has limitations onto the number of chaplains they can hire, or is it because there are not many Muslim chaplains out there?
I don't think it's because of the amount of chaplains the trust can hire. I think it depends on the inpatients that you have. So if you have a high level of inpatients who are from that particular faith background, then it would necessitate for you to have X amount. So how they work it out, I think nationally, is for every 35 or it used to be worked out, every 35 inpatients would equal to 1 session of chaplaincy. That means 7.5 hours. So it's a little bit like, it's a bit of a cost sort of exercise or a business case that they would put forward. And also I have to say that there is something about staff who make judgments for chaplains. So the amount of times I've been told, excuse me, sorry, can you leave? It's not visiting hours. And I'm thinking, well, I'm not a visitor. I've got my lanyard. I'm very clearly, you can see that I've got, you know, my badge identifying. So there's some really poor attitudes from staff. And Christian, I know that my Christian colleagues do not get the same, because they have a collar so they can see them coming. I don't have a uniform or anything, which I'm trying to push that we should all have a uniform. So the whole chaplaincy service, whether you be Christian or a Muslim or a Sikh, so at least we are all identified as you know, you can see them coming. We have a fantastic relationship within our team with all the diversity that we have. And I don't think that many of the hospitals are lucky enough. But I suppose in your positions of being in the positions that you are, it's something, if you feel that there's a need for it, because I know that there's some of the work that I've done with patients with Dr. Ali, there's definitely been a need for Muslim chaplaincy, and it's been a really win-win situation, because it's about the holistic approach and not just looking at a patient medically. So that's where I come in as a chaplain to say, well, you know, Dr. Mansoor will be here for this part, the nursing will do the nursing part. What about all the other things? And it's joining those dots up together, or the jigsaw pieces, and you're sending the patient, you know, looked at holistically and in a much better way. So it's worked really well. And I think if it's something that you can push, it's definitely, I would push it if it's a need. And coming back to Dr. Ali's question around something that I would like to, and I think as a something that have you ever thought about prior to me talking to you today? You know, what are your feelings about what chaplaincy can do for you, apart from Christian chaplains? And I think you've mentioned that, you know, they come. What do you think a chaplain can offer you in your line of work?
Good question.
Yeah, it's something I'll be very honest, I never thought about it. And something sort of, you know, in our day-to-day practice, we just go to work, we do our bit, and then, you know, stop there. That's sort of my personal experience, but I'm sure people would have a different kind of an approach.
I think Dr. Imran wants to make a comment. Dr. Imran, go ahead. Dr. Imran, you wanted to make a comment? You are unmute.
Naseem, I'm not sure, is it you're asking me, Imran Mushtaq? Because I have not asked for a comment, but I can make a comment.
Yes.
So, yeah. So Shaheen, I'm a consultant child and adolescent psychiatrist. We are based outside Sheffield Children's Hospital, but whenever we need a Muslim chaplain, we can request and actually they can provide. Usually they say that is we need, if we ask for at least a day before. So, but I have never actually asked them whether they are on ad hoc basis or they are employed by them.
Yes, so as far as I know, with Sheffield and like ourselves, we are running on a 24-hour, 7-day, 24/7 service. So what happens is after 8 o'clock in Bradford, the on-call service kicks in. So it would go through switchboard, and if you've got a situation where it's quite critical, a life and death situation, and if it's not even a life or death situation, you've got a patient who's kicking off and is not, you can't calm them down. So these are some of the things that I would come out for. You've got a patient who's very distressed and is not complying with the staff. And I've come out at 12 o'clock at night, and this is how we work. And I suppose it comes down to the person themselves as well. So I don't think it's the training. I have a high level of patience, and I suppose it's the age as well, you know, so, you know, being quite old, dealing with, you know, and lots of my previous experience, I've dealt with lots of antisocial behavior, working in domestic violence, being a teacher. So I suppose it's all the skills that I've brought to the job. I'm able to deal with some of the patients, and a lot of the children matters, mental health. So there's so many things that we deal with as chaplains. When patients don't want to take the tablets, for instance, and they're refusing treatment, that's something which chaplains are called for often within our trust. And we work slightly differently than the consultants would work or the doctors.
No, I think you're absolutely right. I have used few times Muslim chaplains, especially in young people with psychosis, where they would have no insight and they will not take medication, or parents have a limited insight in terms of how to work them. I have seen that Muslim chaplains have actually, they have done a great job for us.
Oh, that's fantastic. And if ever you wanted to ever talk about something, and I'm not saying that I'm the right person, this is something which we have, especially in Bradford, but you might tell me if you've got a bigger problem, is when you talked about psychosis, is this person has been affected by Jannat. This person is under the
yes, yeah.
That's a massive problem within the Asian community. You know, somebody's going through a midlife crisis, somebody's done something on them, or they, you know, there's been witchcraft involved, this person's got Jannat, you know, please look at them, how. So when we get these kind of patients, you should see, and I know I'd love to share stories, but I know that we haven't got a lot of time, but really successful in terms of how we deal with these patients with the clinicians, whether it's the psychiatrists or, you know, the doctors or the nurses looking after that patient.
Thank you.
Yeah.
Thank you. Excellent.
Mansoor, I don't think there are any more questions.
Yeah. No, I don't think there's any more questions. Thank you very much. Thank you, Saad, for such an excellent presentation. Saad, I think colleagues would be actually wondering whether what's the outcome of that lady's sort of treatment, and now is she on dialysis? What is she doing? Could you just elaborate something on that?
Yeah, I also wanted to actually ask this
Yes,
question. What happened to her? Yeah.
Thank you.
So far her renal function is stable. She was counseled for dialysis in the event that she does need it. But right now, we're really going down the route of query antiphospholipid syndrome and just referring her to our hematologists and rheumatologists. I think the rheumatologists are not too convinced because they see so many raised antiphospholipid antibodies. We're working her up in the thrombosis clinic. From a renal perspective, she's doing quite well, actually. And the anticoagulation did seem to hit the spot. But absolutely, who knows what happens in the future? But yeah,
yes,
so still pending.
So, thank you very much for that.
Mansoor,
yeah, go on.
it's Ahmed here.
Yes.
I've got a question for Saad.
Yes, go ahead.
Which is the safer sort of NOAC in renal patients?
I think that question, Dr. Ali, you may have to rescue me, but as far as I'm aware, they're all quite similar, but they're not really appropriate in a GFR less than 15 or 20 or something.
So
I mean from ease of prescribing and monitoring point of view. Obviously, they all can be given, but which one would you actually prefer?
Yeah, so Saad's actually not a renal sort of trainee at the moment, so he had done some renal jobs. So basically, to answer your question, Amir, there is actually obviously nice backing for apixaban compared to other agents, including warfarin. So I would preferably go for apixaban, 5 milligrams, obviously using the ABC criteria. When the creatinine clearance hits to 15 or less than 15, there is no such evidence or guidance to actually use of apixaban or rivaroxaban in that setting. Not that you can't use it, you can. In the US, they do use it, but unfortunately, there's no licenses to counsel the patient, especially when they start actually on dialysis, because there's no evidence or there's no sort of randomized controlled trials for its use in creatinine clearance of less than 15. I have not used dabigatran because obviously actually of its heavy renal clearance. I have used apixaban and rivaroxaban, and in some patients who are approaching dialysis, I still use them, but justifying and keeping the rationale in mind with the patient. I've not used edoxaban. I know that's sometimes being used. Obviously, there are lots of other sort of actually studies. Sorry, you're saying something? So I would be fine, and for CKD stage 3, 4, there is actually nice guidance basically using apixaban in preference to warfarin in patients who've got one or other risk factors, such as stroke, heart failure, or chronic kidney disease. And
Mansoor, do you reduce to 2.5? Because
yes,
in stroke, if creatinine more than 137,
133,
and
yeah,
age more than 80 or
80.
weight less than 60, we reduce to 2.5 BD.
2.5 milligrams, yeah. I once actually had a GP writing to me that this kidney function, this patient's kidney function declined. I have reduced the dose of apixaban to 2.5 milligrams once a day and rationalized the medication. But I said, well, that's not the right dose. You've got to give me the right dose. Right dose should be 2.5 milligrams BD. But yes, I'm answering your question. I do use apixaban and rivaroxaban in patients as long as the creatinine clearance is more than 15, less than 15. I do justify it if I use it, because don't forget, warfarin sometimes can cause a lot of problems in patients, especially with regular and erratic sort of bleeding. So yes, and on dialysis patients, unfortunately, there is no such studies, but if we have in our units used DOACs in patients who are intolerant or have got side effects with warfarin, especially in patients with calcified access, where warfarin is one of the causative risk factors.
Thank you, Mansoor.
Thank you.
Thank you very much. I would like to conclude the session. Thank you again, Shaheen and Saad, for an excellent talk. We had an excellent session today. Thank you all for joining. And we'll
just remind them about the certificate. So Shaheen, I will be sending yours and a Saad certificate, whereas everyone else could just download from the Dropbox. You've mentioned that, Naseem, haven't you?
Yes, the link is shared in the chat. Thank you very much all.
Shaheen, you've got a question?
Not a question. I think somebody put in the comments, and if they wanted my details, I'm more than happy for you to share my details, Dr. Ali.
Yeah, that's fine. I'll pass it on to whoever's actually asked for. No problem.
Thank you very much. Thank you, everyone. Take care.
Thank you. Thank you.
Thank you. Bye-bye.